Dear students, welcome to today's vital and intriguing session on cancer cell characteristics and the stages of carcinogenesis. Initiation, promotion, progression and termination, an essential exploration of the molecular and cellular foundations of cancer biology. This will guide us through the stepwise journey of tumor development, linking fundamental mechanisms to clinical implications for deeper understanding. The learning objectives of today's session are to critically evaluate the historical evolution and conceptual foundations of cancer biology, to analyze the fundamental hallmarks and molecular characteristics of cancer cells, to elucidate the molecular and cellular basis of carcinogenesis across its stages, to assess the role of tumor microenvironment and the host factor in cancer development, to integrate molecular insights into clinical applications and research contexts of cancer biology. Dear students, we will now start with introduction and historical perspective of cancer biology. Cancer, derived from Greek word karkinos, which means crab, has been recognized since ancient times with breast tumors documented in Egyptian papyri around 3000 BCE. Historically, Rudolf Virchow's 19th century work established cancer's cellular origin, while modern genomics has identified over 500 cancer-associated genes. Hanahan and Winberg's Hallmarks of Cancer framework unifies its key traits including sustained proliferation, resistance to cell death, replicative immortality, angiogenesis, invasion, metabolic reprogramming, and immune evasion. The study of cancer biology reveals it as a multifaceted group of diseases characterized by uncontrolled cell proliferation, tissue invasion, and metastasis, driven by accumulated genetic mutations, epigenetic alterations, and chromosomal instability. It is not a single disease, but a group of disorders characterized by uncontrolled cell growth, invasion of surrounding tissues, and metastasis of distant sites. At its core, cancer arises from cumulative genetic and epigenetic alterations that disrupt normal regulatory pathways of proliferation, differentiation, apoptosis, and DNA repair. Carcinogenesis is a multi-step Darwinian process encompassing initiation, promotion, progression, and termination, shaped by genetic predisposition, environmental factors, and cellular microenvironment. Tobacco smoke radiation and oncogenic viruses exemplify external carcinogens, with nearly 10 million deaths annually worldwide. Cancer remains a major health burden. Understanding these molecular and clinical aspects is vital for advancing diagnostics, therapeutics, and precision oncology research. Dear students, we will now see the fundamental characteristics of cancer cells. Cancer is a complex disease defined by distinctive traits collectively known as the hallmarks of cancer. These hallmarks, first proposed by Hanahan and Winberg in 2000 and later expanded in 2011 and 2022, describe biological capabilities that distinguish malignant cells from normal cells. They arise through genetic mutations, epigenetic alterations, and interactions with the tumor microenvironment, and together drive tumor growth, survival, and dissemination. Next is the uncontrolled proliferation. Normal cells tightly regulate the growth via receptor-mediated pathways such as EGFR and PDGFR. In cancer, mutations in proto-oncogenes like RAS lead to constitutive signaling, enabling cells to divide independent of growth factors. Tumors may also establish autocrine loops, secreting growth factors they respond to themselves. Downstream cascades like PI3Ka, AKT and MAP kinase remain persistently active, fueling proliferation. Next is the evading growth suppressors. Tumor suppressors act as brakes on proliferation. Loss of RB1 disrupts G1S checkpoint control, while mutations in TP53, the guardian of the genome, eliminate the ability to halt the cycle or repair damage. Viral oncoproteins, for example HPV E7, also inactivate these safeguards, leading to unchecked division. Next is resisting cell death and achieving immortality. Normal apoptotic pathway eliminate damaged cells. Cancer resists these by overexpressing BCL2, mutating pro-apoptotic factors, for example BAX, or silencing death receptors. Moreover, cancer cells bypass the Hayflick limit through telomerase reactivation or alternative telomere maintenance mechanisms, granting limitless replicative potential. Next is the angiogenesis and metastasis. Beyond a minimal size, tumors require new blood vessels for oxygen and nutrients. They achieve this via VEGF secretion, often driven by hypoxia-inducible factors. Therapies like bevacizumab target this process. Invasion and metastasis, the primary cause of cancer mortality, involve epithelial to mesenchymal transition or EMT, reduced cell adhesion, E-cadherin loss, extracellular matrix degradation or the MMP secretion, and colonization at distant organs. Tools such as liquid biopsies help detect circulating tumor cells, offering insights into early metastasis. Advances in cancer biology have expanded the hallmark list to include reprogrammed energy metabolism or the Warburg effect. Tumors rely on glycolysis even in oxygen-rich environments, facilitating rapid ATP and biomass production. Immune evasion. Tumors express programmed cell death, ligand 1 or the PDL1 to inhibit cytotoxic T cells, a mechanism countered by checkpoint inhibitors, for example, pembrolizumab, nivolumab. Next is the genome instability. Defective DNA repair genes, for example, breast cancer gene 1 and breast cancer gene 2, which is the BRCA1 and 2, accelerate mutation accumulation, fueling cancer evolution. Tumor-promoting inflammation. Cytokines like tissue necrotic factor or the TNF from recruited immune cells create a pro-cancer microenvironment. Additional capabilities include the non-mutational epigenetic reprogramming, polymorphic microbiome, and senescent cells and phenotypic plasticity add further complexity. Dear students, we will now see the molecular basis of carcinogenesis, genetic mutations and genomic instability. Genetic instability is the driving force in cancer evolution. Mutations in DNA polymerases, mismatch repair genes, and double-strand breaks repair pathway contribute to accumulation of errors. Next is the epigenetic regulation. Epigenetic changes include DNA methylation, histone modification, and non-coding RNAs. Hypermethylation of promoter region silences tumor suppressor genes, while global hypomethylation leads to chromosomal instability. Histone modifications alter chromatin accessibility, influencing gene expression. We will now see the role of oncogenes and tumor suppressors. Oncogenes such as RAS or the RAS, MYC and HER2 drive proliferation and survival when mutated or overexpressed. Tumor suppressors like tumor protein 53 or the P53, retinoblastoma protein, adenomatous polyposis coli or the APC, and phosphatase angiotensin homolog or the PTEN normally act as guardians but are often inactivated in cancers. The balance between oncogene activation and tumor suppressor loss dictates malignant transformation. We will now see the DNA repair mechanisms. Defects in DNA repair pathway predispose cells to carcinogenesis. For example, the BRCA1 and 2 mutations impair homologous recombination, predisposing to breast and ovarian cancers. Similarly, defective nucleotide excision repair underlies xeroderma pigmentosum characterized by extreme UV sensitivity and skin cancer risk. Next are the stages of carcinogenesis. The first stage is the initiation. Molecular mechanisms of initiation, the first stage of carcinogenesis triggers rapid, irreversible genetic alterations in normal cells via carcinogens, setting the stage for malignancy. DNA damaging agents like ultraviolet radiations or benzopyrene in tobacco-induced mutations in proto-oncogenes, for example, cross G to T transversions, or tumor suppressors, for example, tumor protein P53 point mutations. Types of initiating agents. Chemical carcinogens include direct-acting alkylating agents, for example, N-nitroso compounds, and pro-carcinogens like aflatoxin B1, activated by cytochrome P450. Physical agents like ionizing X-rays, non-ionizing ultraviolet rays, and other biological agents like human papilloma virus E6, E7 inactivating tumor protein P53 or retinoblastoma drive mutations, with postgraduate research using the EMS test to assess mutagenicity. Dear students, we will now see the cellular response and fixation. Initiated cells may undergo tumor protein P53 mediated apoptosis or repair via base excision repair or homologous recombinations. Unrepaired mutations fix during synthesis phase, creating latent cells. Polymorphisms in repair genes, for example, X-ray repair cross-complementing protein 1, increase cancer risk, particularly in smokers. Next is the promotion. Characteristics of promotion. Promotion, the second stage, is a reversible process where initiated cells are stimulated to proliferate through non-mutagenic agents and expanding the clone without further DNA damage. Unlike initiation, promotion requires prolonged exposure and is dose dependent, often involving inflammation or hormone signaling. Promoting agents and mechanisms. Chemical promoters like phospholasters activate protein kinase C or the PKC, mimicking diacylglycerol to stimulate growth pathways. Hormonal promoters, for example, estrogen in breast cancer, bind receptors upregulating cyclin D. Next are the cellular and molecular events. Promotion enhances proliferation via mitogen-activated protein kinase or the MAPK. Activation evading apoptosis through BCL2. Next is the progression. First are the hallmarks of progression. Progression is the irreversible phase where promoted cells acquire additional mutations, leading to invasive metastatic tumors and increased heterogeneity. It involves genomic instability and selection of aggressive clones. Next are the molecular drivers. Accumulated mutations in oncogenes, for example, MYC amplification, and suppressors, for example, PTEN loss, drive epithelial mesenchymal transition or the EMT. Angiogenesis via vascular endothelial growth factor or the VEGF supports growth. Metastasis and invasion. Cells degrade extracellular matrix via matrix metalloproteinases or the MMPs, invading blood or lymph vessels, circulating tumor cells or the CTCs, seed distant sites. Last is the termination. Termination in carcinogenesis. Termination, sometimes called as the end stage, refers to the point where the tumor becomes fully malignant, autonomous, and potentially lethal. Though termination is less commonly used, some view it as the final progression to death or remission. At this stage, the tumor often becomes unresponsive to standard therapeutic intervention, reflecting its complete independence from normal regulatory mechanisms. For some cancers, termination may also represent clinical remission following successful therapy, highlighting the dual interpretation of the concept. We will now see the characteristics of terminal cancer. Advanced tumors exhibit anaplasia, rapid growth and resistance to therapy due to mutations. For example, MDR1 for drug efflux. Cachexia and organ failure mark this stage. In addition, patients may experience severe systemic symptoms such as chronic pain, immunosuppression, and profound weight loss, severely affecting quality of life. The prognosis is usually poor, with treatment shifting from curative intent to palliative care to relieve the suffering and maintain dignity. We will now discuss the molecular and clinical aspects. Genomic chaos with high mutation burden, for example, in melanoma. This instability often results in extreme heterogeneity within the tumor, allowing survival of resistant clones even after aggressive therapy. Clinically, biomarkers at this stage may indicate high-grade malignancy and poor therapeutic response, guiding physicians towards supportive management strategies. Next are the prevention of terminal stage. Early detection via biomarkers, for example PSA for prostate cancer, halts progression. Screening programs and molecular diagnostics enable identification of precancerous or early stage lesions where interventions are far more effective. Lifestyle modifications, vaccination, for example HPV vaccine, and chemopreventive agents further reduce the risk of cancers advancing to a terminal stage. Dear students, now moving forward to the role of tumor microenvironment. The tumor microenvironment, or the TME, is increasingly recognized as a dynamic and integral participant in carcinogenesis rather than just a passive background. It consists of a complex network of stromal fibroblasts, endothelial cells, immune cells, and extracellular matrix, or the ECM components, all of which interact closely with tumor cells to shape cancer growth, invasion, and progression. Among these, cancer-associated fibroblasts, or the CAFs, are particularly important as they secrete growth factors, cytokines, and proteolytic enzymes that not only remodel the ECM but also create pathways for tumor cells to invade surrounding tissues. Similarly, tumor-associated macrophages, or the TAMs, contribute to both tumor survival and immune evasion. By secreting vascular endothelial growth factor, or the VEGF, and other pro-angiogenic factors like the TAMs stimulate the formation of new blood vessels, ensuring tumors receive an adequate supply of oxygen and nutrients. At the same time, they suppress cytotoxic immune responses, helping cancer cells escape detection and destruction. Another critical aspect of TME is chronic inflammation, which creates a pro-cancerous environment through the reactive oxygen species, or the ROS, and inflammatory cytokines that promote DNA damage and genomic instability. Furthermore, hypoxic conditions within tumors stabilize the hypoxia-inducible factor 1 alpha, which is the HIF-1 alpha, which upregulates VEGF and drives angiogenesis. Collectively, these interactions highlight the TME as a therapeutic target in modern oncology. Next are the examples of carcinogenesis in human cancers. The first one is the lung cancer. Cigarette smoke contains polyclinic aromatic hydrocarbons and nitrosamines that act as initiators. Repeated exposures provide promotional stimuli with mutations in KRAS, EGFR, and P53 drive progression. Targeted therapies such as EGFR tyrosine kinase inhibitors exploit specific molecular alteration. The second one is the cervical cancer. Human papilloma virus, or the HPV infection, integrates viral DNA into host genomes. Viral oncoproteins E6 and E7 inactivate P53 and retinoblastoma respectively, promoting initiation and progression. Persistent infection and inflammation act as promoters. Vaccinations against HPV is an effective preventive measure. The third one is the colorectal cancer. The adenocarcinoma sequence exemplifies stepwise carcinogenesis. Early APC mutations initiate polyp formation. Cross mutations promote adenoma growth, and P53 loss enables malignant transformation. Lynch syndrome illustrates the role of defective mismatch repair in carcinogenesis. Next are the carcinogenesis and clinical implication. A detailed understanding of carcinogenesis is the multi-step process of initiation, promotion, progression, and termination, has transformed how cancer is diagnosed, monitored, and treated. By studying the molecular and cellular mechanisms that underlie tumor development, clinicians can identify biomarkers that not only aid in early detection but also provide prognostic and therapeutic insights. For instance, HER2 amplification in breast cancer guides the use of targeted therapies such as trastuzumab, while prostate-specific antigen or the PSA testing enables early intervention in prostate cancer. The rise of precision medicine has introduced therapies designed to specifically block oncogenic drivers or restore tumor suppressor pathways. Monoclonal antibodies and small molecule inhibitors such as imatinib in chronic myeloid leukemia have demonstrated how selectively targeting the molecular lesions can improve survival and reduce toxicity compared to conventional chemotherapy. Similarly, immune checkpoint inhibitors, including the anti-PD-1 and the anti-CTLA-4 agents, revolutionize therapy by empowering the patient's immune system to recognize and destroy tumor cells. Beyond treatment, cancer prevention is an equally important clinical implication for carcinogenesis research. Strategies such as chemoprevention, for example, aspirin reducing colorectal cancer risk, vaccination, for example, HPV vaccine against cervical cancer, and lifestyle modifications like avoiding tobacco, healthy diet, physical activity highlight how a mechanistic understanding of cancer can translate into reduced incidence and improved public health. Dear students, in conclusion, the study of cancer cell characteristics and the multi-step process of carcinogenesis reveals the intricate interplay of genetic, epigenetic, and environmental factors in shaping malignancy. Let this knowledge inspire you to deepen your curiosity, pursue innovative research, and contribute meaningfully to advancing cancer biology and patient care. This was all about today's lecture. I will see you next time. Thank you.